Hi, everyone. Thanks for coming. Welcome to session 5 of the NOAHE Evidence into Practice Luncheon Series. Today, our presenter will be Dr. Chris McCabe, who is the CEO and Executive Director at Institute of Health Economics. Please welcome him.
Thank you very much. Thank you, Hannah, and thank you, everybody, for coming and spending your lunch hour with me. This is the first time I've given this lecture. Completely new set of slides, which is an increasingly rare occurrence as you go further and further on in your teaching career. So it's quite possible that I have under or overestimated how many slides I'm going to need to fill that. I'm thinking I'm going to talk for about 45 minutes, and then there'll be time for questions. If we get, you have questions as I go along, don't hesitate to interrupt me. I'll just talk more quickly afterwards. Okay? So today I'm talking to you about the economic evaluation of social interventions, and trying to talk about the challenges. What's different when we're talking about social, societal interventions, public health interventions. Okay, so when we are talking about societal interventions, we're often interested in equity explicitly from the get-go. It's almost the differentiating characteristic of taking a public health or societal intervention, health promotion intervention approach, is that actually we can be driven by a concern for inequity in health. And I'm sure many of you have seen this before, that the difference between equality and equity, and we're often interested in trying to improve equity, which often can mean actually positive introduction of inequality, and it's quite difficult for those of us who are privileged, and I stand here as a professional middle-aged white male, about as privileged as you can get, and it's hard for us to give things up, to admit that we will have to get less in order for others to get more. And that means that whenever we go into a policy discussion where we're trying to propose that the majority of the people around the table are going to give things up in their personal life, because we tend to be the people around the table, the quality of the evidence that we need to put before the decision makers to make that change really has to be very high. We have to have thought things through much more carefully than maybe for a simple should we fund this drug or not fund this drug for this patient group. And I think the good thing is that health economics has actually been wrestling with this issue from its own end of the telescope, probably for the last 2 decades. And we've been making a lot of progress. And I feel that the health economics research and methods community are kind of meeting the public health community in the middle as we travel towards each other from our different ends of the telescope. And that's kind of what I'm going to talk about as some background before I get to the meat of the what are the challenges of evaluation of societal interventions. Okay, so briefly going to recap health economic evaluation. What do we mean? And I'm going to talk about the ever-extending scope of economic evaluation, and this is what I mean by the journey that we have been on, moving towards a greater consideration of understanding of equity in economic evaluation, and then talk about the relatively recent literature that explicitly looks at the distributional effects of introducing technologies or policies, etc., and how you can, proposals that are out there in the literature for modelling those effects explicitly. And then I'm going to flip over and talk about societal interventions. And I'm going to motivate some of my discussions on the points I want to make, illustrate the points using mental health promotion in schools, because that's obviously very topical here in Alberta. And it's a great example for us to understand some of the challenges. A little bit of definitions, won't take long there. And I think there's two groups of challenges. There's technical challenges around evaluation, methods, and types of evidence. So I'm going to spend a wee bit of time talking through those, and I suspect that's the stuff that most people thought they were coming to listen to today. So that's the space where very happy to be, to have a conversation as much as actually me didactically telling you things. And hopefully we can motivate that conversation using the mental health promotion in schools example to unpack some of the issues. And then I'm going to talk about the challenges around decision making, which is more in the policy space. But quite often we observe that getting these policies funded can fall over because the costs may fall on one budget and the majority of the benefits fall on another budget. Is there a mechanism for thinking through in a systematic way those multi-sectorial challenges such that we can help decision makers who are responsible for different budgets navigate those challenges such that society doesn't miss out on valuable societal interventions, public health interventions, simply because of budgetary silos? Okay, so that's what I'm going to talk about, and then I'll summarise at the very end. Okay, so remember, economic evaluation in healthcare is a comparison of the costs and outcomes of two or more alternative healthcare technologies. Healthcare technologies in its broadest sense. So it can be a service, it can be a package of care, it can be a talking therapy, it can be a device, it can be a drug. But it's not just a widget of some sort. Okay. The costs that are considered are those borne by the payer, plus or minus other public sector budgets typically. And the outcomes can be clinical measures, quality adjusted life years, or monetary values of health. The output of an economic evaluation is then compared to some reference index, a cost effectiveness threshold, or a willingness to pay for health to decide whether the specific technology is good value, should be invested in, funded, reimbursed, whatever phrase your particular decision maker likes to use. So that's economic evaluation as we conventionally do it. Almost from the outset of economic evaluation being used as a policy analysis tool in healthcare, the question was asked, should we take account of the productivity of costs associated with the illness being treated? Should we incorporate that? And importantly, if the technology being evaluated reduced those productivity costs, should that be taken into account? And if it should be taken into account, then they're netted out of the costs from the costs of healthcare. And there's an interesting methods debate about if you're going to do it, should you use the human capital approach, which assumes that lost work is all of the value of the displaced work is lost, or should you use another method, the friction method, that says, well, actually, there is a pool of unused labour that will be used to come in and take over that work if somebody's out of the labour market for an extended length of time. So we call that friction costs. I think most people would argue, unless you've got close to full employment, actually the friction cost method is theoretically more appropriate. It's messier technically, but it's not that hard, and human capital costs will overestimate things. But the principle that productivity costs should be incorporated is still strongly debated. An under-considered component of this discussion, I would argue, is the equity impact of incorporating productivity costs. Privileged people like me, well-educated, middle-aged white males, our productivity costs are higher. So if we value health improvements partially in relation to the value of our labour in the market, actually I am, all things being equal, more likely to get funding for a technology I will benefit from than women, people from ethnic minorities, etc. We all know the fixed and, as far as anyone can figure out, utterly unrelated to the value of productivity, differences in income. So if we add productivity costs in, we're buying into a particular equity position. And we should do that explicitly. Personally, I'm emotionally uncomfortable with that equity position. Personally, I would benefit hugely from it. I think the most important thing is that we recognise that there's an equity domain to expanding the scope of what we include in economic evaluation of healthcare, which means that those of us who are well rewarded in the labour market are going to have our health more highly valued and therefore are more likely to get technologies that benefit us funded. And as ill health is not unrelated to socioeconomic status, it's going to impact upon the comprehensiveness and the equity of access to healthcare. So, unintended consequences in an equity space. So, despite all of that, the recent last year Washington panel statement of good practice for the US on economic evaluation of healthcare came out in favour of adding in productivity costs. And a lot more. The next thing that got raised in the literature was, well, healthcare costs. If we keep people alive, they don't stop consuming healthcare. If we cure your cancer, the reality is you're going to die of something else. We're all going to die of something, and we will pretty reliably consume healthcare whilst we wait to do it. So every extension of life commits us to unrelated healthcare costs. Should they be taken into account in our economic evaluation of the technology? It's a cost the technology imposes on the system, even though it's not related to the treatment of the target condition. So again, an additional scope. Put forward in the early mid-1990s, people feel a discomfort about it. Because all other things being equal, it reduces the likelihood that a technology is going to be considered cost-effective, because it just increases the cost associated with using a more effective technology. So we kind of feel a bit uncomfortable. But intellectually, if those costs fall on the same budget as the technology that you're evaluating and that the decision maker is responsible for, intellectually there's no reason why you shouldn't include these costs. So it's uncomfortable because it puts us at a higher risk of saying no. And we don't like saying no, unfortunately. If you have to take account of unrelated costs, surely you should have to take account of unrelated health issues. So we know as we age, we have typically more than one health problem. We have multimorbidity. So there was a nice report from the UK a couple of years ago that looked at a community and found that the median number of conditions per person was slightly over 4.2. The range was 0, unsurprisingly, young people, etc., all the way up to 70, which I found absolutely stunning. But it was a complete community population. It wasn't a sample, it was the whole thing. Comorbidities impose limits on your ability to benefit. We have historically and typically assumed that the patients we treat are otherwise healthy in our evaluation of the benefit of the technology. And so we assume that they have an average all-cause mortality risk, separate from their cause-specific mortality risk. But the thing is, ill health is clearly correlated. If you've got one thing wrong with you, you probably have other things wrong with you. And so that attribution of an all-cause mortality is probably overstating, or often there is a risk that it will be overstating the life expectancy gain. And it may well be overstating the quality of life gain. If you've got pain from two disease processes, and your treatment alleviates the pain from one disease process, you've still got the pain from the other. And yet we assume, conventionally, you don't. So in ignoring multimorbidity, we've probably been pretty systematically overestimating the value of new technologies and new treatments. So it seems sensible that if we're going to have unrelated healthcare costs, it's not internally coherent to ignore the unrelated health losses. If we just have one, not the other, we're not being internally coherent. So again, extend the scope. Think about multimorbidity. And that's just extending the scope within the identified individual. We all live in social groups. So this is where you see my argument we're starting to move towards placing everything in society, in its societal context. Very few of us, thankfully, have nobody who cares about us. There's enough, and we need to do something about those people, but most of us exist in a household. And as we get older, we have people within our household who care for us. And our health and our use of healthcare impacts upon their quality of life, and indeed can impact upon their use of healthcare services. So these are factors which fall under the remit of the healthcare budget. We're interested in population health. So this first really came to light when we started to look at the newer drugs for Alzheimer's, when there was an argument made that it kept people independent at home for longer. And that was deemed to be a good thing. And it was argued that it actually, in keeping people independent for longer, you would improve the quality of life of their carers. Studies tended to, some studies empirically observed that actually there comes a stage where keeping the individual at home longer when they have a higher level of dependence actually harms the carer's quality of life. Okay? But if we are interested in population health, population quality of life, as something we're trying to achieve with the healthcare system's budget, it seems coherent and rational to take account of the carer's quality of life. And obviously changes in quality of life will drive utilisation of healthcare system. And so we get a particular, slightly different version of unrelated healthcare costs that we might want to take into account. Also, it plays into displaced work. If we have to take our aging parents to the hospital, then that takes time away from our work. Speaking from my own household's perspective, there's been issues with our children that have occasionally led to my wife taking 6 months off work completely. So productivity costs comes into play. And again, we have this equity dimension. Those of us who live in families, well, we're more likely to have a caregiver effect to take account of. People who live alone may be substantially disadvantaged by not having those effects. And because diseases are not randomly distributed through the population, we could expect to see some systematic equity effects of incorporating these caregiver effects into our economic evaluations. Caregiver effects are a specific example of a broader category called spillover effects. So we now know that having an ill family member impacts on your health, even if you are not the carer. It actually impacts on your health and on your utilisation of the health system. So again, ill health takes place in a social context. The indirect impact, it may be indirect, but it is predictable and quantifiable. So shouldn't we incorporate it into the evaluation of a technology? And again, we get that same story. Well, that gives us an equity dimension. We'll start reallocating. If we bring these in, then those technologies that are deemed more valuable will not impact equally across the population we serve. So there's an equity dimension to this. High-income people may well do better out of this, and low-income people may well do worse. Empirical questions, but we would expect to see some effects. So what would I say? Well, I would say what I've talked you through there is a story of the development of health economic evaluation over the last 3 decades that can be characterised as expanding the scope of economic evaluation, expanding it in terms of which costs and effects should be included and whose costs and effects should be included. Underlying it, this fundamental recognition that ill health and healthcare take place in a societal context. And actually, all healthcare interventions are to some degree societal. We can't understand their value if we put them in a silo. And it's just the patient who receives it, and it's just the costs that are incurred by the healthcare system, and it's just the benefits that are received by that patient receiving it. We will get the wrong answer. But as soon as we acknowledge that we have to go broader than that, then we start having predictable and potentially unwanted equity effects on how we distribute healthcare and access to healthcare and quality of healthcare. Sign-off line. Differences in scope leads to different distributional impacts of healthcare. This is now increasingly recognised. The literature actually started in development, the interface of development economics and health economics. People doing health economic evaluations in developing countries recognised that these distributional effects were really important. And we started to see people developing extensions of cost-effectiveness analysis, economic evaluation, to either, at minimum, describe the equity effects. Recognising, so this is from a lovely paper. The last slide is a bunch of references. This is from the Cookson et al. Paper, and it's just a fantastic overview of the field. I highly recommend reading it. So this is from that paper by Richard Cookson and colleagues. And essentially, we have 4 types of intervention or categories for this purpose. Those that are cost effective and improve equity. Great, they're our win-win. We've got those that are cost effective and harm equity. Well, there's this equity efficiency trade-off. We kind of talk about that quite a lot in places. We have those that are not cost effective and harm equity, which they're the easiest ones. This sort of the lose-lose and the win-win are easy from a decision-making perspective. The difficult ones is this lose-win, something that's cost ineffective but improves equity. So to give you a specific example that I know about, in the UK when we looked at having a national policy to fund smoking cessation, nicotine replacement products, it was very clear they were not cost effective in the least socioeconomically advantaged groups because adherence in those populations was less. But they were so hugely cost effective in the educated populations and socioeconomically advantaged that the average made them cost effective. So the policymakers explicitly just pointed to the average figure. That's all that was put in their decisions, in their documents that went out to the world, reasonably cost effective. Because actually it was felt, I think everyone would agree, really important that those with the greatest need got access to these. And it was completely an equity-driven decision, funding decision. We funded something for people in whom it was not at all cost-effective from an equity perspective. And then these cost-effective harm equity is the ones that I think we probably have done quite a lot of without thinking about it. The really high-cost cancer drugs, very large budget impacts, usually accessed by people who've already been advantaged because they've lived quite a long time, and that's why they've got to the point of having cancer. So we've been starting to look at this, and what we have is this is just bullet points from that paper, really. Sort of 4 approaches have been developed. Net equity impact, where it says, okay, so what's the net impact on the health in specific pre-specified groups of society that we're interested. So these might be by wealth, or by age, or by gender. That's one effort, and you just break it out for each, and then you get this profile of the distribution of the net health benefits by these subgroups of society we're interested in from an equity perspective. Extended cost effectiveness analysis, this is one that comes out of that developing country perspective, where it's recognized that the coverage of a technology actually has a financial risk benefit. So if we provide a technology, the risk of a household having a catastrophic expenditure because they have within the household, this condition occurs, if it's not covered, their out-of-pocket expenditures to access it will be catastrophic. They will exceed their disposable income. So actually, there is a benefit, a value to that protection of catastrophic risk because it's not equal across all households. You have to have a much higher expenditure for the wealthy than for the poor before you hit a catastrophic expenditure. So putting a value on the insurance protection and how, for those who are less well off, is incorporated in this extended cost effectiveness analysis. Distributional cost effectiveness analysis asks a really important question. It asks not only, as the equity impact does, how do the health gains, how are they distributed across society? It asks, how is the opportunity cost distributed across society? So how we fund the healthcare is really important because that drives who incurs the opportunity cost. If we fund it through insurance, then the impact on less well-off people will be greater because the cost of the insurance premiums in proportion of their household income wealth will be that much greater. So the same technology covered through insurance may have even if it's for a condition that is most prevalent amongst the less well-off, may have a negative equity effect if it drives up their insurance premiums such that what they have to give up in order to still have insurance. So you can have a negative equity effect that outweighs the coverage decision and its positives. So where the opportunity cost falls, how a technology is funded, has an equity effect. If it's through general taxation and we have a progressive taxation system, so those on lower incomes pay less, then the net equity impact, once you've taken the distributional effect of the opportunity cost and the distributional effect of the intervention itself into account, very different. And the fourth bullet under this equity approach is simply asking the question, when we are in this space or this space, what would be the value that we would have to attach to equity to justify that decision? How much or how little would we have to value equity in order for that to be the right decision? So it extracts the implied value of equity of saying yes to a specific technology when it's cost effective but harms equity, or cost ineffective but promotes equity. So just to help the decision makers know what weight they would have to put on equity in order for that decision to be a value-driven decision. Yeah? So that's the story from the economic evaluation of technology's end, and this recognising that they are societal interventions, even though for a long time we've pretended they haven't. If we are really to capture their value, we need to understand them from that societal perspective, crucially including the equity domain. It's taken us 30 years to get there as a profession, but I'm glad we've got there. Now, so that's my summary. Economic evaluation of healthcare is increasingly interested in capturing the broadest possible impact of healthcare on society. A recognition that pretty much all healthcare is in fact a societal intervention. Okay. Now if we come at it from the officially a societal intervention end of the telescope, as I think about it. So here's this, I think societal interventions, another name for public health interventions, in its purest form. And I love this definition from Donald Edgson, the UK Faculty of Public Health. Defined it as the science and art of promoting and protecting health and well-being, preventing ill health and prolonging life through the organised efforts of society. And we've got one, as I alluded to earlier, a really current example where let's put money in for mental health promotion and protection through the education system. And this is, as I understand it, Alberta Health Services, or Alberta Health, the government, putting money into the education system, in essence, or making things available via the education system. So we've got two relevant budgets. You know, we have the education budget and the health budget. And if we were to look at an economic evaluation of mental health promotion just within each budget, what would we think about? So here, if I was thinking about from the education, should I spend education department money on this? Well, what am I going to, I'm going to incur staffing costs, administration, economy, accommodation, consumables, overheads. what might I want to see more of? What might be my outcome of interest? Well, school attendance, just the kids physically being there. You know, that might be my reason that I don't want kids depressed at home alone. Having them in the school environment, exposed to education. I might be really kind of utilitarian and say, you know, education's all about producing kids who've passed exams. And so I'm just interested in their grade 12 attainment. What proportion of kids who enter grade 10 come out with their high school diploma? I might be interested in behaviour. I might want to see, well, if we put this in, do we have fewer meltdowns, either in the classroom or in the hallways? Do we have fewer fights, fewer conflicts with teachers? I just might want to see better behaviour because kids who are happy tend to behave better, so who are comfortable with themselves. I just might want to have better behaviours. I might want to say, well, I'll know they're happy if they're engaged in our community. I know they're in a better place mentally if they're engaged in there. So if we see more of our students being parts of the sports teams, I'm not saying they've got to win, just being part of the sports team. So, you know, when I was at school, you had to get on a sports team, you had to be contributing to the likelihood of winning. That's the UK, it's all very aggressive like that. Yeah. We got here, and to find my eldest son being on the Skona cross-country team because they win every year by making sure they've got the biggest cross-country team there is in the city. And it was just the taking part, and his engagement was an educational success. And it was really alien, but it's a good thing. You might also want sporting attainment. You might actually say the only point of educating people is so that they get a job. I don't care whether they get their high school diploma. I want to see if supporting their mental health through high school means that more of them leave and get a job. Or you might be really elitist and say, well, I want to see how many of them go to university. It's not that they get a job, but actually that we put them on a track for really high-end jobs. Any of those would be perfectly reasonable effects, and they're utterly or nearly utterly irrelevant to what the health system might want to buy. We might want to see longer life expectancy. We might want to see improvements in their quality of life. We'd certainly want to see reductions in self-harm, and definitely want to see reductions in suicide attempts. The costs that we would incur and think about if we were evaluating it from the healthcare system, well, their utilisation, their EMS, their prescriptions, the EDs, admissions, family doctor contacts, therapist contacts, those would be all the things that I'd want to take account of. The overlap, the correlation between these two things, fine, but the actual overlap between these two things, vanishingly small. You could imagine quite easily that both budgets would look at this and say, it's just not good value. Actually, the costs I incur are going to be too much for me to pay for the education budget. And health say, yeah, but its impact on life expectancy is too small for it to be good value from the health budget, even though I make a bunch of savings. You could do these two evaluations independently, and both departments would quite rightly, from their perspective, say, I'm not paying for it. And that's a problem when all of the evidence that looks cross-sectorally says the return on investment on these things is just huge. By the age of 21, we have very good, positive net present values. And this is true for a lot of public health interventions. So in the reading list, I've included a review that came out earlier this year on the return on investment for public health interventions. And it's just over $14 for every dollar spent. The equivalent figure for healthcare is about $3.80 for every dollar spent. Okay. So these things are often very good value, but when we look at them from one sector's budget alone, it's quite possible that we say no to them. And that's a problem, it seems. So, societal interventions. For the purposes of the remainder of this talk, I'm talking about interventions that have multiple objectives and face multiple constraints within and beyond the healthcare system. So the constraints I'm talking about primarily are budget constraints. They may also be capacity constraints in terms of the availability of the skills required. Multiple constraints implies multiple decision makers, and again, they have different objectives. What on earth can we do? Okay, so challenges for evaluation. Well, the objectives of the different decision makers, how do we translate those? You know, how many high school diplomas equals one quality adjusted life year? I have absolutely no idea. Types of evidence. You know, we like our randomized controlled trials. It's the gold standard in health. How you analyze that data, how you synthesize that data, it's a really, you know, we've got a purring, smooth machine. We know what we're doing. Randomized controlled trials in education, maybe not so many of them. Much more observational. Prospective observational studies, much more typical in education literature than randomized controlled trials. Administrative data, it's the new big thing that's going to solve all our problems in health. I don't think we have anything like patient electronic record systems in education. That minutiae data, that's not a place we're going. And then really importantly, levels of activity. Most of our health technologies we deliver in a really tight space. And their effectiveness, we're relatively comfortable about our ability to characterize the magnitude of effect. The role of, so it's very much at the individual level, the role of community and environment as strong determinants of the effectiveness of public health interventions. How engaged is the community in delivering this package of behaviours? It can be really important. Is it deliverable? Are there countervailing factors in one community that aren't there in the community in which we tested this? That dissemination, can it be done? The role of the levels of the activity of the intervention is so much more important in education. You know, when you try to disseminate something in one environment that you developed in another environment, you hit behavioural and structural barriers quite often. Quantity of evidence. RCTs of school start time is actually not bad. It's got 11 randomised controlled trials that tell us we should give in and let our adolescents stay in bed later in the morning. RCTs of antidepressives for the same is nearly twice as many. So the quantity of evidence and then the quality of evidence. I don't know how many of you have heard of the Campbell collaboration. So they do the same job for education, environment, social work as the Cochrane collaboration does for healthcare. 7,549 Cochrane systematic reviews compared to 147. So much more uncertain because we have a lot less high quality evidence. Given the differences in the nature of the evidence, what we are going to look to the statisticians and data analysts for methodologically to get magnitude estimates. Because that's one of the things about economic evaluation. It's not does something work, it's how much it works, because that determines how much it can cost and still be good value. The role of statistical inference from observational data going to become much more important. We're going to have to be using instrumental variable analysis, difference in differences analysis. We can't assume that what we observe is a true effect without methods to model the counterfactual. Okay, so the real challenges, substantial challenges to the methods of the evaluation and the types of evidence. We know how to do most of these things. We've done a little bit, but the importance of different methods is just going to be radically different. Our ability to do a meta-analysis for randomized controlled trials, not so much. Challenges for the decision makers, well, different budgets. So we spend 21.4 billion on healthcare and 9.6 billion on education. Does this reflect the relative social value of education and healthcare? Are we saying that at this point, the marginal utility of education, so the value we attach to the last unit of output or effect in the education system, is exactly equal to the value we attach to the last unit of output in the health system? I have absolutely no idea whether this reflects our relative value of health and education or not. But if it doesn't, it's we can't directly map benefits in education onto benefits in healthcare, add them up and come to a conclusion about the net benefit, the total societal benefit. So we have a problem. The evaluation problem can be solved. There you go, it's a mathematical programming. So this is from the paper by Claxton, Mark versus Luke. Lovely paper, please read it, really. Do that bit. So what are we saying? We're interested, first of all, we solve it for health. So it's just a mathematical programming. We solve it for health and the health budget. And then from that, we solve it to other budgets. Now, it's a lovely piece of math. But the information requirements for us to be able to utilize this math just cannot be met in the real world. We can't do this. And so we have to acknowledge that there isn't a simple mathematical solution, and we're going to have to be pragmatic. And the pragmatic solution is to focus on that marginal change. So standard HTA, what we're saying is this technology is either more valuable than the marginal technology it displaces, or it's less valuable. And if it's less valuable, we shouldn't adopt it. So we don't have to worry about all the other technologies, just the least efficient, least valuable technology we currently pay for. That's what we're thinking about. And we can take the same approach for the education budget. What's the least valuable thing that we spend on education? And we're interested in those two things, looking at the margins of the two budgets. And we can define the net benefit of health, the marginal value, or the value of the marginal technology in health. And we're simply asking, so is it positive in health? You know, this is currently what we do for HTA. And we do the same thing in education, knowing that because we've got a different budget and different objective, lambda E won't be lambda H. Okay. And then we can apply a simple compensation test. First of all, we can identify the easy ones. If both our net benefits are positive, then it's easy, we do it. Okay? If they're both negative, it's easy, we don't do it. These two, we have a conversation between the budget holders. We can tell health how much it's going to have to compensate education. Or education can say, well, for me to incur these costs, you're going to have to give me this much extra money. Or the other way around, we can say from education, this is how much of your budget would have to come into us to compensate for the loss that we would get. And we can identify the circumstances where actually it's too much. What would be required for compensation is too much, and therefore health can't compensate education, or education can't compensate. So what we're saying here, this pragmatic compensation solution approach, is to identify the no-brainers, yes, no, and then identify the scope in which a negotiation between the two budget holders is needed. Doing them on a clear evidence base. So it's not ignoring the multisectoral perspective. It's not pretending we can treat it as all a single perspective and as just one decision. We're respecting the multi-sectors, their different objectives, different budgets, and creating a clear negotiating space where we can give an evidence base for education that's, well, I need this much money from you, health, for us to be able to partner with you moving this forward, or the other way around. So it's a really pragmatic solution that, really importantly, doesn't pretend that it's not a multisectoral problem, and doesn't pretend that there's a unique social solution. It recognises the realities of the siloed budgets. So summary number 2, direction of travel in economic evaluation, I would say, is increasingly societal. Health and healthcare impact upon society. Society impacts upon health and healthcare. Doesn't matter which end of the telescope you're coming from, that's what's happening. There are specific challenges in evaluating societal interventions. Technical, methods ones, and types of evidence ones. We have the toolkit, but we haven't used them very much in healthcare. So we're going to have to get more comfortable with them and get better at using them. And there's the social value questions about, well, what's that lambda, what's that marginal value of education and that marginal value of health, and how do they relate to each other? And how do we have a discussion about that? But conceptually, the HTA, I call it the decision analytic framework, so the decision-oriented framework that we've used in HTA, can be extended for societal interventions via this intersectoral compensation process. So this is hard stuff to do in process terms and in decision-making terms, but it can be done, and we shouldn't just throw up our arms and walk away.